Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. What could be better?
It's after the workday. It's been a bit of a marathon to get to today, in terms of, there's just a lot of stuff going on. Had a busy OR day, and then it actually turned out I ended up a little bit early, and then I had enough. It was like enough of a time to not be in a complete rush to get home, but I was able to pick up my son from soccer practice, got dinner ready, and then had some extra time in between. So went outside, threw the ball around, hung out. It was a nice day.
Oh, but the weather here. So, a couple things. One, my middle child is moving to Boston this weekend, so excited for her. And one of her favorite things to do is go sit on in Forest Park on Art Hill. Just sit, eat dinner, read a book, whatever. So we went last night and read a book, and it's indescribable. On a nice day, it's indescribable how wonderful that experience is. Lots of people out, crazy, great.
Yeah, no, we cannot tell people how great it is to be in St. Louis during certain times of the year because then everybody would want to move here. It'd be almost like Nashville or something. So in case you're wondering, St. Louis is just an okay place to live. But it has been wonderful. I had a friend in town over the weekend from residency, and it was great catching up with her. She brought her kid, hung out with the Burks family. It was really a fun time catching up with everybody, and the weather was, like you said, unbeatable.
Yeah, funny story from last night. So I'm a little tired. And the reason is, I don't know about you, but somehow or another we've gotten in the habit is when we go to sleep, we turn on our alarm system. And I don't know why we do that, but we do. And, you know, so occasionally, I don't know if you do it, but occasionally when you do that, the alarm will go off,
Mm-hmm.
right? So at 3 this morning, the alarm goes off. And,
Oh.
your heart rate goes from whatever it is to like 200.
Mm-hmm.
And of course, Talia didn't budge. Kylie's asleep in her room, and I'm like, Talia, get up. And then, I go downstairs to explore. Of course, it was nothing, but
Right.
you can't go back to sleep after that, or
Yeah,
it's
yeah.
hard.
That's a tough one for sure. So that's a nice way to start your day.
A little earlier than expected.
Yeah, so we're excited about tonight's episode or today's episode, whatever it is. We have a few things to discuss. We have a great review that was left on iTunes, a 5-star review. That's the only way to leave a review. We've had some feedback on our recent episode about quick pearls for carpal tunnel surgery, so we're going to share those. We have a great case a theoretical case, of course, that we're going to discuss about ulnar-sided wrist pain. And also discuss another listener email about just things about, after you book a surgery, after you talk to a patient, how you actually get that case to the OR. So obviously that'll be very dependent on the system you work in, but happy to share pearls. We really do appreciate hearing from everybody. We've had topic suggestions left on reviews recently that we'll share, as well as additional topics and feedback. So handpodcast@gmail.com. To the people that have left some emails regarding distal biceps, we are going to get to those. And I know that there's a clamoring for some reason about a tennis elbow episode. So maybe we can have one of our therapy colleagues, the famous Macy Stoner, will come on, and that'll be part of the grab bag we discuss with her.
That sounds fantastic. Let's kick it off with a review. What could be better than a review?
Absolutely. So amazingly, we've had two reviews in the last few weeks. So thank you. This is from Mandy3. She said, like Dr. D, I finished fellowship 10 years ago. Man, 10 years ago. I've had great mentorship after fellowship, but I also would have welcomed this podcast when I was a trainee and new attending. I am so gratified to have some of my own observations verified and to learn some new things too. I was at a wash you type place where if we don't do it, no one will, and had to learn quickly. Also great, Dr. Boyers never missed the opportunity to do nothing. So thank you, Mandy. Awesome review. Appreciate it. Definitely helps us feel good about the time and the effort that we put into this. Every time we do it, it's like, well, when are we going to do it? Then it's like, well, it was really super fun. So thank you again.
Oh, that's exactly right. Before we hear about some quick pearls from listeners about carpal tunnel, The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
Awesome.
So, we had an episode recently about pearls for relatively straightforward cases. was actually doing a carpal tunnel release recently with a mid-level resident and who was kind of working with me because my current fellow Nick Robbins is in India on his microsurgery training trip, and it's always interesting to go between different levels of trainees and what they are really good at and what
So
they
true.
have not experienced yet. And then we were talking a lot about how the carpal tunnel release is a retraction case and the little pearls for retraction. So this is from Oren Franco, former guest on the pod and a former Cincinnati Stern Kiefhaber graduate. So he mentions that he's still listening and enjoying the pod, and he graduated from that amazing Cincinnati fellowship and basically does the same thing that we do for carpal tunnel. However, he now uses the nasal speculum for every single case when going proximal. He finds it less frustrating than trying to create the box with three separate Sen or Ragnell retractors. It's effectively a one-handed near circumferential retractor and gives him a lot more control. Every ambulatory surgery center has them because they're a very common tool for ENT, and it looks exactly what you would expect, a very small speculum. So he said maybe we could find one that works for us, and he says it's undervalued, under discussed in the hand surgery world. So I have heard of people using this technique. It's just not something that I've looked to because I've always, even if I don't have a trainee with me, kind of figured out a way that I feel comfortable and safe doing a proximal release. But what do you think, Chuck?
It's a great tip. Yeah, we're fortunate that our surgery centers, or at least most of the ones I work at, don't have ENT. Tomorrow I work at our children's specialty care center, so they do. But yeah, not a easy access for me. I think it's a great pearl and makes life a lot easier, especially for those who have fewer hands. But the Kiefhaber box retraction technique still does it for me.
Yeah, I actually do work at a surgery center that has an ENT surgeon. I think it's a single ENT surgeon. So I will ask about this just to learn a bit more and check it out. So Oren, thank you for the email. Thanks for continuing to listen to the pod. And again, we love having the feedback from everybody. So thank you again for sharing that. Let me pull up one more tips and trick. Just give me a second here. My computer is not exactly cooperating, but here we go. This is from Joe Rosenbaum, friend of the pod. Joe, thank you again for listening and for writing us in the past. So he has another, wow, Cincinnati everywhere here. So he says, credit to Jing Jing Zen from Cincinnati. For carpal tunnel, you won't always have those skilled hands. So instead of all those sends, try a 3-2 wheat laner. It's the smallest one, helps spread a tissue, makes everything easy to use, very compatible with Volant. So what do you think, Chuck? Do you ever use a wheat laner for this kind of case?
I'm not a weedy guy. I think in certain patients, it's a home run. I think in patients where retraction's a little more difficult, then it doesn't work well for me. And again, I'm fortunate to always have, not always, but mostly have a trainee with me, and I can, done this with nurses. I think it's a good tip. It's just not a total home run for me. But Jing Jing was a Wash U medical student, and then did her fellowship in Cincinnati, and I believe she's attending in Rochester now. WashU, Cincy path for many.
Yes, I hear it's a well-established pipeline, so to say. I like the wheat laner. So when I'm doing a carpal tunnel alone, I will use a wheat laner for the exposure. Once I've gotten through that layer where I'm now exposed my superficial palmar fascia, gotten underneath that, that's where I typically would advance the sen a little bit deeper if I had somebody with me. But I do like using a wheat lander there. I tend to shy away and use a blunt one just because the one tine is heading towards that fat with the ulnar bundle, and sometimes there is that separate, well-described branch coming off of the ulnar artery proper that runs over the distal aspect of the TCL that you can get into if you use something sharp. So I like a blunt phone for there, and then I will occasionally just leave it in if I'm going proximal. The trick is making sure that you somehow kind of lean your body weight or your forearm weight onto the retractor so as to keep the palm flat, because it will quickly guide you into Guillen's canal if you don't have somebody holding that or using your own weight to do that. So yeah, no, I like that, Joe. Thank you for sharing that. And I do like the wheat lantern in that situation. There is one more pearl that Joe shares here.
Let's hear it.
So trigger finger. So he calls this a Ragnell surgery, especially a trigger thumb. You may need 3 or even 4 Ragnells. If you're alone, a Heiss works. He does a longitudinal incision except for a thumb. So what do you think about that? I totally agree. It's a Ragnell case. So for me, it's I like an oblique incision, kind of based on where I am. If I can sneak one into the crease, patients like that party trick. But if once I make my skin incision, then the rest of it's a Ragnell case. It's one Ragnell on each side of the flexor sheath, and the blunt end of a sen going distally to expose the leading edge of the A1 pulley because I tend to tuck my incision at the leading edge of the A1 pulley.
Yeah, I do what you do, but I agree that Ragnells are far better for this case than Sens. The only case where I use three typically Ragnells and no Sen is the pediatric trigger thumb, because you can't get a Sen in the right spot. So for that case, it's three Ragnells. Otherwise, it's two Ragnells and a Sen. But I think Joe's totally right. If you can get your hands on three Ragnells, we just have two in our set typically. Then I think he's right.
Completely agree. I mean, every time I mention it, I tell the person holding the sen, if it's not me, don't stab yourself in your glove with the sharp end of the sen because it's always kind of hanging up out there. So Joe, thank you for that for those tips. I really appreciate it. If anybody has any pearls or they want to share about common procedures, clearly they're common, so everybody could benefit from a different perspective. So please send those in to handpodcast@gmail.com.
All right. Should we thank our other sponsor before we jump into a listener submitted topic?
Absolutely. The Upper Hand is sponsored by Checkpoint Surgical. Checkpoint's Guardian Nerve
Come on.
Stimulator. I know. I was thinking it's the blue one. If you're confused, it's the blue one. Okay. So the Guardian, the blue one, isn't just for peripheral nerve surgeons. It is widely used across a variety of orthopedic procedures, including distal and mid shaft humerus fractures, forearm fractures, elbow fractures, and revision elbow surgery for reliable nerve identification and protection.
Discover how Guardian can support you in the OR by visiting checkpointsurgical.com or by connecting with the Checkpoint team. Awesome.
I've
So,
never flubbed the checkpoint copy, so I'm sorry, Becca. First time for everything. I will say a couple of things. If you are not a peripheral nerve surgeon and you're not a hand surgeon and you're using this thing, remember, if you have to have, because it's the blue one, you have to have the grounding lead into soft tissue, okay? And then know that it will not work if your tourniquet's been up for a very long time. Okay, so the dogma is somewhere between 20 to 30 minutes before tourniquet related ischemia kicks in. Our paper from me and David shows that probably about 45 minutes, depending on how high you have the tourniquet, at least with the Guardian. Okay, but just when you apply and you use this device, the yellow light has to be blinking to know that you're actually conducting to the tip there. Because if you don't have the grounding lead in, the red light will be on and the yellow light will not blink. And then you won't have any favors done for you if you have tourniquet related ischemia. It will still blink yellow, but it probably will work.
interesting. Thank you. That's helpful for me to hear for sure because I don't use it very often. I do have a couple set aside that recently expired, and our partner, Dr. Wall, is going on a mission trip in about 2 week and a half. And so I'm going to send those with her. Good use if she needs them.
Absolutely. Hey, Checkpoint, I know that you supported mission trips in the past with stimulators. Step up. Dr. Wall's got a trip coming. You got to hook a lady up there.
All right. I like this scenario. Do you want to guide us through this or you want me to?
Yeah, well, we could go through the scenario for sure. So let's see here. So we've got a hypothetical, very young 49-year-old male with dominant right wrist pain that's ulnar sided for 9 months who has failed splinting, therapy, NSAIDs, and saw temporary improvement from a steroid injection prior to the referral, assuming this is a steroid injection placed in the right place by somebody that you trust. How do you think about this patient?
Yeah, I think your point that you led with is really an important one. Steroid injections done by someone else are always tricky because the patient has no idea where the injection was. Hopefully you have a note, but we all know that that doesn't always happen. And so trying to discern where the injection was given is really important. I think most people give intra-articular steroid injections dorsally through what I would call the 3-4 portal. I tend to put them in through the 6R portal, but I think that's less common. So ulnar-sided injections, I would suppose, are ECU tendon sheath injections, but can be either. How do you think about injection location?
So I think I will I will inject patients who have ulnar-sided pain through 6R. I will inject patients with non-ulnar-sided pain, like so the more central and dorsal pain, through 3-4. I just yes, theoretically, if you're in the right place, it should all kind of flood the zone and get everywhere, within the radiocarpal ulnar carpal articulation. Uh, but I don't know. I just tend to follow that dogma that you just go where the pain is.
Yeah, and 6U injections are possible. I think that's absolutely well stated. The one thing I do feel strongly about is if I'm giving an ECU injection, I do it at least a centimeter proximal to the wrist joint. I don't think that prevents steroid from necessarily communicating with the wrist joint, but I just want to do what I can to keep it out of the wrist joint to better understand, results. ECU injections are interesting. It's one and one only for me. I've seen too many cases of fat atrophy that can be severe in that location, even if you try to keep the injection deep. So one and one only there. Intra-articular injections, for reasons we all know, I don't do injections over and over and over again in the radial carpal joint.
So, when you say one and done for an ECU injection, I thought you were going to lead us to the fact that you're worried about a tendon rupture, not the subcutaneous atrophy, which clearly is a risk. I've seen that before for like really bad for like the Quer veins
Mhm.
in particular, which is to me, that's why that's a one, two, then done type of injection. But I guess I thought you were going to be more concerned about attritional rupture from a steroid injection at the ECU.
I haven't seen that. I think that's legitimate concern, but I haven't seen that. And I think it's an injection. I don't know how you technically do your ECU injections. I'm at least a centimeter proximal to the onocarpal joint, and I sort of go in parallel to the dorsal aspect of the ulna, and I sort of go down to the bone and then inject. So I'm not injecting. I really try to be careful not to inject in the tendon, but I do use the bone to help me, which I think is a reasonable approach. How do you do your ECU injections?
I try not to.
Yeah,
But
fair.
are you doing your injection from dorsal to volar? Or are you when you say use the bone, are you actually going more mid-axial and ulnar and then using the bone and then kind of going just slightly dorsal to where the bone is?
Yeah, for those YouTubers, I'm going mid-axial and ulnar, and you can sort of see my ECU tendon. Wow, this is good. Um,
Because you're
I'm
ripped.
ripped. Those tendons are looking good tonight. I'm going in right here, proximal to the wrist.
RFK is just embarrassed by how ripped you are. So, the will you inject? This is slightly veering from the
We
original
have
topic, but
veered.
yeah. So, are you injecting patients with instability of their ECU or only tendonitis of their ECU?
Tendonitis, and so I would say tendonitis and a positive ECU synergy test. If there are listeners who don't know the ECU synergy test, look it up. I'll put it in the show notes. It's a great article.
Why don't you show us, Chuck?
I will show you. Supinated elbow flexion, a little short of 90 degrees. The way I do it is to ask them to make a big five, keep your fingers apart, and then I try to squeeze together the index and thumb. And in doing so, you have to fire your ECU tendon.
Co-contraction of the ECU while you're firing your first and second and
Oh, sure. Say it
first,
fancy.
first and I guess first and fourth compartments there, but yeah, maybe some of the third.
Yes.
Um,
So,
Okay. So simple, like you have them, like we have those little exam tables where, you can roll it out and they're sitting down. I just have them put their elbow on it, face your palm, spread your fingers.
absolutely. And a little resistance helps. And if that recreates their pain, you have your answer. And usually when people have ECU tendonitis, they complain of pain that shoots up the ulnar side of the forearm. It's not always, but it's another good history tip. So if we have history, an exam, an ECU injection is great. It can work, can provide information. And if it's all, if you don't have ECU tendonitis, then you think about intracarpal pathology, such as the TFCC.
Now, do you couple that, if you think it's ECU tendonitis as what's leading your differential, are you coupling that with specific form of therapy or bracing or anything like that?
I absolutely start with that. I don't find it to be terribly successful. So, a course of anti-inflammatories, a wrist brace to rest, and some, therapy for, I don't know, calming things down can be helpful. I just don't know that I have seen a great deal of success, but I think I give our therapist a chance. I don't think it works for a lot of people. I don't know if you've had better success than I.
Yeah, I know. I like it, but I don't fully understand how it works. I mean, I get it. I've seen the literature on dynamic stabilization of the ulnar side and strengthening of the ECU and FCU and all the stabilizers. I understand why it works. I don't get it entirely, how that's going to quiet down an inflamed tendon. I think it's probably the anti-inflammatories, which in this case have already been tried. I like a wrist widget, to be honest with you. It tends to provide the support and the hug on the other side of the wrist that patients tend to like. And then I think a lot of it's activity modification.
So the wrist widget is the most important pearl that we can possibly give you. The problem with the wrist widget, as if you use it as a treatment for one thing, it helps everything on the ulnar side of the wrist. And so because it helps you, you don't know what the diagnosis, but the wrist widget's great. Our therapist will make them. You can go on Amazon and buy them. It's essentially a neoprene sleeve that you can tighten. It's better than tape because it doesn't loosen. So it is a home run that I recommend at least 2 or 3 times every clinic.
Yeah, I recommend it too much, but yeah, I think it's available on Amazon. The trick is just getting it to fit on your own if you if you get it online on your own. So for this case, so it's been 9 months, and let's say, for example, you feel like ECU tendonitis or instability much lower on your differential. They had a steroid injection that got some relief. Are there particular things on your clinical examination that are making you think more ulnar sided versus radiocarpal pain, aside from maybe where they're hurting?
Yeah, let me just hit, if I may, the highlights of my exam. Listening to the patient goes without saying. So first, when I start my exam, I don't want to go through the whole exam, but I start at Lister's tubercle, go distal, and I'm at the SL, go a little ulnar, I'm at the lunate, and then for most people, you can then feel the LT. So that's the first palpation maneuver. Drop down from the LT, you're feeling the DRUJ, which is rarely painful in my experience. And then dorsal and distal to the ulna, that can be uncomfortable. And then the gold point is the fovea. So if you go feel the ulnar styloid, go a little volar to it, really between the styloid and the pisiform, that's the fovea. And there has been tests which confirm, studies which confirm that if you're sore at the fovea, in all likelihood, you have a TFCC tear. You might have synovitis, but that is the critical assessment, is the fovea. I also palpate the piezotriquetral joint, much less common, but can be arthritic. And then lastly, I do two stress tests on the ulnar side. One is the LT, which is a shuck, and the other is the DREJ, which I test in pronation, neutral, and supination. And I think we are terrible at testing DREJ stability, although I do it all the time.
Yeah, if there was only somebody who was scientifically trying to evaluate our ability to
We're
to
trying.
ballot the distal off radial ulnar joint. I think I mentioned this when you guys were in the lab. You're working with one of our soon-to-be partners and our former fellows, David Wright, on doing something in the lab. I remember as a medical student trying to tackle this question and having all the tech scan sensors and everything. And I'm glad that somebody who is smarter and better resourced will be tackling this question again.
Yeah, we've done some good work, and we're writing up some of our work now. And David, if you're listening, we need to finish that. But yeah, we don't have the easy solution, and maybe the ultrasound is the best solution, honestly. But it's just not been a hot topic in the ultrasound world yet. Maybe we can make it one. So just to
I mean, talk
close,
about a dynamic assessment, right? So.
yeah, couldn't be
I have
better.
one question before you bring this to a close. So you described and showed people where you palpate the fovea, but I think it's probably just very useful to say, like you said, it's between the styloid and the pisiform, and that's basically your mid-axial line. If you just feel where the styloid is and go just beyond it. So have you found, I've seen and I like the ulnar carpal supination test in which you stabilize the distal ulna and supinate the carpus, the ulnar side of the carpus relative to that stabilized distal ulna. Do you feel like that adds anything to your exam? It's probably a lot of overlap with with your foveal tenderness.
I really do. I played with that. I played just supinating the forearm without specifically the carpus to understand tension on the TFCC and to understand whether it recreates pain. So forced supination, either the carpus or radius and ulna, and forced pronation as well. Far more commonly, forced supination does recreate pain. And the other test I didn't mention is ulnar carpal impaction, so ulnar deviation. What gets confusing, and hopefully people don't discount a patient's response. Radial deviation can create pain also in these situations. On the ulnar side, I think that's more tension and synovitis type pain rather than the impaction type pain pinching the TFCC. But that's just the way I think about it.
I have not found impaction maneuvers to be useful aside from a live fluoroscan assessment in which the impaction maneuvers are coupled with looking at whether there is bone impingement. So that's just my experience as a non-sophisticated ulnar wrist pain person.
Yeah, and there's some people that want live C-arm while holding a weight.
Hmm.
And I get that. There's good data that suggests that's the best way to understand dynamic ulnocarpal impaction versus static. And it's all important. It's obviously a complicated topic. Sanj Kakar, who's been a guest, likes to talk about the clover leaf with the four common causes. But I think it's experience. And the one thing I tell our fellows is every time we do a risk scope, you should carefully review the MRI beforehand and then do the scopes, find what we see, and then carefully review the MRI afterwards. I think there's no better learning that we can do.
Yeah, same thing for us with the plexus when we're looking at the MRI, and then because I'm still trying to get better at actual images on the MRI for the plexus, and our protocols are getting better too, as well as the nerve studies in response to interop stim. Anyway, I had to make it about nerves. Don't worry, we won't talk about denervation today, although I know somebody's going to put that in the chat.
Yeah, maybe. I'll close it out by saying this patient in my hands gets a scope with an expectation that A will identify the issue. In my hands, often it is the TFCC, and we can rehash that. We've done it before, but we can rehash that another time.
Are
So
you going to get, has this patient usually had an MRI along the way, I'm assuming? And if not, if they haven't gotten one, would you get one? What kind of study would you get, plus minus arthrogram? And if they've already had one, would you then repeat the study prior to surgery, even if you think surgery is in the offing?
no, I discussed that with the patient, and some patients feel strongly that they want the MRI. I'm not against an MRI. I also think my clinical assessment plus the planned arthroscopy gives us what we need to know. For some patients who've not had it, an MRI can make some sense. And a lot of patients don't, like if I offer a cortisone injection in the office, some patients don't want that without an MRI. And so I don't think it's wrong to get an MRI. At our institution, we have pretty good quality magnets, and so I never do an arthrogram. I don't think it helps me. And patients don't like arthrograms, and so I usually just do a plain MRI, and I've had good information provided by that.
So typically, I think one of the arguments for an arthrogram, in addition to potentially a better quality image, would be looking at extravasation of contrast between the radiocarpal joint down the sigmoid notch, so-called J sign, versus extravasation into the to the midcarpal joint. Do you feel like your exam beforehand is able to get you that information, or do you feel like your fluoroscopy or your arthroscopy is going to get you that information anyway, perhaps at a better quality?
Pretty strong feelings. So arthroscopically diagnosing SL and LT tears is not hard. You got to know where to look. You assess the scapholunate through the 3-4 portal and also through the midcarpal radial portal. You assess the LT through the 6R portal because you cannot see it through the 3-4 portal and also through the ulnar midcarpal portal. So you can have good visualization. I would argue strongly that it doesn't help you with the TFCC either because the only way it likely gets into the DREJ, the dye that is if there's a radial sided or a central tear. You shouldn't miss a radial sided or a central tear arthroscopically. If you have a foveal tear, if you have a dorsal or volar tear, it doesn't always get through those tears into the DREJ. And so I don't think it answers the question definitively. And therefore, I'd rather use a plain MRI plus an arthroscopy to, get the most information.
So for this hypothetical patient, are we thinking what percentage of patients that get to the OR with you who get an arthroscopy are getting debridement alone, foveal repair, and ulnar shortening osteotomy?
We have gone down the rabbit hole. Maybe we need to save the other topic for another time, which we can. And I may be criticized for saying this, and Sanj and I have talked a lot about this. 10 years ago, I debrided a lot of TFCCs and I repaired outside in technique dorsal ulnar tears or peripheral tears. And some patients got better, but I would have to say it was a surgery that was good but not great in my hands. Today, with ulnar-sided wrist pain and presumed TFCC, 90% of patients have a foveal tear. So these are patients that haven't gotten better, have continued pain, have failed various treatment options, sometimes for really long times. And so most of them have a foveal tear. It is possible I'm overly aggressive in making that diagnosis, but I'll flip it on its head and say that patients get better. And so those are patients with micro instability, and those are patients with macro instability, the DREJ. And I've been really happy, and I am doing a ton of wrist scopes. And I think that's because, other people don't love it and haven't had the kind of good fortune that I have lately. But my practice is now wrist scopes and elbow scopes. It's fascinating.
That's quite a pivot because I mean, I remember being your fellow 10, 11 years ago and seeing your practice has even just shifted, towards more arthroscopy. And some of that is practice patterns and who likes doing what. And we're blessed to have people that like doing certain things and people who like doing other things. And it's a pretty nice split. You know, it is interesting conceptually to think of what if you just shorten the ulna? Would that ever be enough, even for those foveal tears? Because that was brought up by a listener when we had one of our other wrist arthroscopy episodes about, why even do the debridement? Just shorten the ulna for the non-arthroscopy inclined.
It is impossible to argue against that. Shortening the ulna makes a big difference. And I can't, first of all, I think that many patients, especially the adolescent population that I scope and or repair the TFCC, also get a shortening. That to me is a no-brainer. If you have an adolescent that there's neutral or positive variance in TFCC pathology, they get a shortening, a formal shortening. And then if you're not an arthroscopist and your patient has ulnar-sided wrist pain, it is typically, I won't say 100%, but typically highly appropriate to just shorten the ulna and you'll get a good result. It's just one of those things that to me is I want to fix the root of the problem. And if that's the TFCC, I want to fix the TFCC. But because I don't think ulnar shortening in the setting of a foveal tear, especially if there's instability, I don't think it is always the answer. But shortening the ulna provides stability, decompresses the ulnar wrist. So there's a lot to it.
Well, I think that we were at the point where we almost took another deep dive into sports, but we saved ourselves. I did want to say, why don't we go through just a couple of the questions asked in this? Because I think it'd be good maybe is to sprinkle some of these questions in some future episodes. And again, if anybody has any topics they want us to discuss, especially at this kind of transition point of the year for residents, fellows, and for new people in practice, please let us know. So this is from Todd Alter. Thanks for writing in, Todd. He said he just graduated his fellowship. He's going to be starting practice pretty soon. If not, right now, he says he's been thinking a lot how to ensure he was planning surgeries effectively when he starts out without missing important details. Let's go through maybe the first few. So he asks, Dear Professor Goldfarb, once you've indicated and consented a patient in clinic for surgery, how does the workflow proceed from there?
Yeah, so I meet the patient, I'm in the room, I talk to the patient, and then ultimately they have to make a decision if they're ready to schedule. And in my practice, I'm sure in yours, patients often come in knowing what their options are, having seen others or seen me, and then we schedule them that day. I have a little form I fill out that says what I need, expected length of the surgery, diagnosis, and procedure, and then the surgical consent. My nurse then comes in, answers some questions, and then she takes it, enters into Epic, and gets the schedule done. I then don't see the patient or talk to the patient unless there's additional questions until the day of surgery. In our situation, they meet anesthesia the day of, but there is typically a telephone preoperative assessment by anesthesia to smooth the day of surgery and ensure the patients are appropriate for the outpatient setting. I'm pretty confident that's how your flow works, but maybe things have changed.
Yeah, a couple of details in between. So, the typically the patients always ask, when can we do it? And I tell them to ask the boss, as we mentioned in the past episode. I did get some pushback in a recent encounter about a patient saying, she's not your boss. It was anyway, usually works pretty well. And then we fill out the form very similar to you. I will list everything because it's next on the next
Mhm.
question. I will list everything on there that I want on the consent that I think is appropriate. That will help both me, the patient, and the OR all prepare for the case. Um, the special needs and stuff, I tend to put on whatever I think is appropriate in terms of equipment. Sometimes that's mini C arms, sometimes that's specific implant sets. I mark on there if I specifically want the OR to call the rep, but usually they do just because it makes at least at our place, the OR's life a little bit easier. The person that's with me, for me, it's Hannah. She's my athletic trainer. She's awesome. She will consent the patient, and have them sign the consent form, in the moment. I know other people like to write that out themselves. And then consent form gets scanned. She will then, at some point within the next day or two, enter the surgery herself. We don't have separate surgical schedulers, which I think some places do, and also include the anticipated CPT codes. And sometimes I'll be very specific with how I want that listed, and perhaps that's a topic for another day. And Otherwise, it'll be more generic, and she'll do the research on her own, or just has the workflow down for that. prior auth, etc. So yeah, and then in terms of one of the things was how much detail do you need to tell your scheduler? As much as you feel necessary. I think that there are certain things that are more appropriate. If you're, for in my world, if you're doing some kind of extensive neurolysis to mobilize a donor nerve, maybe that's something that you include. And then the other question that maybe we could end with was when consenting patients, are there any items you routinely add to the consent to cover yourself in case of unexpected circumstances in the OR? Now, I remember as a resident, you would always include, repair of neurovascular structures and any necessary procedures. I don't do that routinely anymore. I try to say, possible carpal tunnel release for a distal radius, I'll include.
Yeah, I don't know that I have any pearls in that regard. I don't over consent, and maybe shame on me for not. I try to be comprehensive, but a typical case, for example, would be a wrist arthroscopy, and I just put in cartilage repair. And then if I'm planning an ulnar shortening, and I'll say an ulnar shortening. I don't say debridement of the wrist. I don't say possible ligament repair. I don't even say TFCC. I just say, likely cartilage repair. And I think kind of keeping it broad works in my practice. And I think if you get super specific, it kind of boxes you in a little bit. So I try to keep it true and appropriate, but not too narrow in listing a bunch of different things.
Yeah, I think in my particular world where you do have to be inclusive of that is, for example, if you're thinking you're going to use a nerve allograft, because that has its own CPT code and potentially still has some hard times with authorization or prior auth with certain insurance companies. You better make sure that's prior auth, especially if you work in a private practice surgery setting, because you don't want your surgery center to be on the hook for that rather large expense if the insurance company doesn't cover it. Again, not as much of a concern in our, academic environment, but I have heard about that from other folks.
Yeah, and then one other question that Todd asked, and they're all good, is about how do you assure you have all the equipment? Well, the first step is doing what Chris and I both stated. When you schedule the surgery, indicate what you want. Like if you're removing hardware, just go ahead and do it then, so you don't have to think about it later. I have an extra step I do, which is when I outline my surgical schedule and the design of my two-room day. I also add on that email, which I do 3 days before the surgical date. I add special equipment. So it's that it gets hit twice, and I think therefore it's rare that I don't have what I need.
Yes, I started with that very good habit when I was in exiting fellowship off of your rotation and entering practice, and have not been doing it as diligently except for big cases. But I think I'm in a small enough place where they kind of know my needs. But if there is like a rare case, like it's uncommon or using a new set, for sure I email the resource nurse at the place with enough time so that they can make sure that that's available for us.
Yeah. The last question was, how do you make sure you sleep well the night of surgery? That is a great question. That is the most important question. The first thing is, if you're thinking about it intraoperatively, do the best thing you can for the patient, which might not be doing everything you could possibly do. Um, it's a tough one. I have learned over the years what will keep me awake, and I try to take steps to avoid it. Um, the big ones are obvious. If you're concerned about carpal tunnel in the setting of a distal radius, do the carpal tunnel. If you're concerned about too much swelling in the forearm, do the fasciotomy. But in an outpatient setting, I think it's less obvious how to handle those things. Chris knows, and I've said on this podcast, I call every patient on the drive home. I think it's a nice step. It does put my cell phone out there, but rarely do I get burned with that.
The key is to do it when the block is still on.
Correct.
So
Correct.
I didn't have the wherewithal when I started. We'll close with this, but I didn't have the gumption to do it the day of. So then I started doing it the day after, and that was not that was not ideal.
Bad
But I
move.
do think that it did help reduce burden of calls to the team, fellows on call, as well as the MA that was supporting me at the time. So I think it is the right thing to do. One other thing that I'm trying to work on personally is also to make things easier ahead of time is developing some very customized what to expect kind of handouts that the patients can take with them after they book their surgery, review them constantly ahead of time because the whole question is like, when am I going to get called with my surgery time? When can I expect to my hands? How long is my hand going to be numb? Now they'll either call with those questions beforehand or they'll call with them the day after. So anything we can do with a little bit of effort ahead of time to make life easier for everybody down the line, we're trying to do. So that's been on my to-do list, and I finally crossed it off recently. So
Chat GPT helps with those kind of things too.
damn it. Jeez. All right, now I know. So anyway, thank you for to Todd for the questions. You have a couple others in here. Maybe we'll sprinkle them in throughout some upcoming episodes. And if you have any questions, please feel free to let us know either through a 5-star review or through the email handpocast@gmail.com.
It's been fun.
Totally fun. Have a wonderful evening.
Good night.